Over time, the space around the spinal cord and the neck can slowly narrow. This narrowing can quietly squeeze the spinal cord and interfere with signals that control movement and sensation. Doctors call this condition cervical stenosis. Cervical stenosis compresses the spinal cord, producing progressive neurological symptoms. When symptoms worsen, posterior decompression may be required to prevent further functional decline. Posterior laminectomy removes the laminae, the thin bony plates at the back of the spine, to relieve pressure on the spinal cord and widen the canal. Positioning the patient face down keeps the neck aligned for precise decompression. The midline incision provides direct access to laminae for controlled exposure. Muscles are gently elevated from the bone to preserve their attachments and help reduce postoperative pain. Careful identification of facet margins helps preserve stabilizing structures during decompression. 2 narrow grooves are made on both sides of the lamina so it can be removed safely as one piece. Ligamentum flavum is a thin yellow ligament just under the lamina. Exposure of the ligamentum flavum confirms adequate thinning for safe lamina removal. Once the bone is removed, the spinal canal is decompressed, and the dura, the thin protective covering of the spinal cord, is exposed. Adequate decompression is confirmed when the dura moves freely without any remaining points of pressure. Multi-level stenosis requires repeated steps to maintain consistent decompressive effect. Fusion prevents the neck from developing forward collapse after multi-level laminectomy. If the neck is already poorly aligned or if important stabilizing joints are removed, the spine may need extra support. Lateral mass screws add immediate stability following extensive posterior decompression. Rods align instrumented segments and maintain cervical posture during fusion healing. Bone graft encourages biological fusion, ensuring long-term cervical stability. Surgeons confirm hardware alignment and adequate decompression before closing. Carefully controlling bleeding helps prevent blood from collecting near the spinal cord. Layered closure restores protective tissues and reduces postoperative complications. Imaging verifies hardware position and confirms expanded canal space. A cervical collar may be recommended post-operatively depending on stability and surgeon preference. C5 palsy risk exists but often improves with conservative management. Return to daily tasks generally progresses safely with guided movement restrictions. Most patients gain mobility and reduced neurological deficits after decompression. Follow-up ensures fusion progress and stable long-term alignment.